Today we'll have a beautiful session. Very happy to start this session on a NEET recall. And I like to say that, this year's NEET anatomy questions was actually very straightforward, one-liner questions, not like a previous year's question. It was not like twisted like that. It was a very easy question. Many of the image-based questions were also very easy. So I hope everybody would have answered the anatomy per se questions correctly. And today we will discuss those questions to make sure that correct the every questions in such a way that to make sure that everything goes in order, right? And I'm also very happy to say that many of the questions which have come, at least most of the questions which have come in 2025 NEET exam were already been discussed in our program. Just 1 month before we had this an intensive program, Gorilla Medical Intensive Program, where we have been told by our sir, Dr. Vinayak Sandal sir, to select 100 questions. I was first of all I had a lot of doubt because I'm not going to set the NEET PG question paper, but he told me whatever the question you're going to set must come for the exam. It doesn't matter how you're going to set. I don't know how it is, but only those questions must come for the exam. First I was perplexed. Then our team, we sat and we analyzed the paper, the last 10 years paper, what was the pattern and how they were asking those questions. Where do that pattern leads to? So we were analyzing that and we created 100 questions. The 50 of them we were discussing in our platform and 50 we gave as a test. So from those 100 questions, I'm very happy to say that many of the questions from those 100 has come for this exam. And with that, and a very thanks to Dr. Vinayak Sandal sir for giving us that encouragement and support for preparing those kind of module for our dear students. And with that sincerity and gratitude, today we'll be discussing about the PG NEET Recall 2025 session. So as I told you, many of the questions were all an image-based and a one-liner question. So we will just discuss one by one each question. So first image was this one, which was discussed by our faculty this time. So what was this slide? What was this image? And identify the correct slide here. So the answer is ureter. The answer is ureter because the epithelium, what we are seeing that is a transitional type of epithelium where we find the base will be of columnar epithelium. And as we progress from the base to the apex, we find the epithelium slowly decreases in size and becomes cuboid and becomes an umbrella shaped cells. Okay, you can see these are all the umbrella shaped cells present here, right? So this pattern is seen only in urothelium, right? This pattern is only seen in the kidney, ureter and the bladder, right? The major and the minor calyx, the renal pelvis, ureter, and the pre-prostatic part of the urethra. So only in these kind of structures we have this transitional kind of epithelium, right? So for gallbladder we have the columnar epithelium, and for trachea it is pseudo-stratified ciliated columnar epithelium, and for small intestine it is simple columnar epithelium, right? So this is a typical transitional epithelium which is found only in the urinary tract. So it's a direct question. So there is no odd man out here. So the answer will be ureter, right? I believe many of you have written this one correctly, right? So this is a pattern which we have discussed, right? So urinary bladders lined by what? This is what we have discussed in this just 15 days before the exam. So this is the pattern where I have told you that the urothelium, where the renal calyx is a major, the minor calyx, the ureter, the bladder and the prostatic urethra are all lined with what? Urothelium. That is the transitional type of epithelium. This is the question which we have discussed, right? The next question, a sports person sustains an injury around the shoulder. The physician suspects injury to the long head of triceps muscle. So what is the origin of the long head of triceps muscle? So it's a very direct question. They're asking you the origin of the long head of triceps muscle, right? The choice is given, the choices may be different because it has been recalled by many students. So what are the possible choices which have been recalled? I have put here from our group, right? So the greater tubercle, the lesser tubercle, supraglenoid tubercle and the infraglenoid tubercle, right? So among the 4 options, the direct answer will be the infraglenoid tubercle because the long head of triceps arises from the infraglenoid tubercle, right? So in the scapula we have the glenoid cavity, right? We have the glenoid cavity, right? So in the superior aspect we have the supraglenoid tubercle and the inferior aspect we have the infraglenoid tubercle, right? So from the supraglenoid tubercle arises the long head of biceps muscle, right? A long head of biceps muscle, right? So one beautiful thing about the biceps brachii is that, it is a one muscle which pierces the capsule of the shoulder joint to attach to the supraglenoid tubercle, right? So we can say that the long head of biceps has got an intracapsular origin, right? Intracapsular origin, right? But here the scenario is different for the long head of triceps. Here we have the long head of triceps arises from the infraglenoid tubercle, right, where it do not pierces the capsule. Is that clear? So answer will be the infraglenoid tubercle. So look at the picture there. We find the beautiful triceps, or long head, which arises from the infraglenoid tubercle of the scapula, right? So it's a very simple question. I believe you would have written that one also, right? So third one, which of the following nerve roots are involved in Meralgia paraesthetica, right? So the terminology, the clinical condition, the Meralgia paraesthetica, is where there is where the patient will have the pain and burning sensation in the anterolateral aspect of the thigh, right? It is because of the neuropathy formed from the lateral cutaneous nerve of the thigh, right? From the lateral cutaneous nerve of the thigh. But here the question is, then what is the root value of that particular lateral cutaneous nerve of the thigh, right? For that you have to know the root value. That's why how I train my students in Stanley is, whenever they say any nerve, I always ask them to say the root value along with the nerve. For example, if they talk about the median nerve, they should say median nerve C5 to T1, radial nerve C5 to T1, ulnar nerve C8 and T1. So in that way, so it becomes a default. I make sure that they get the default kind of thing. When they talk about a particular nerve, that means they must say the root value along with the nerve, so as to memorize and keep it a permanent type of memory. So like that. So we have a lot of nerves present in our body. Very difficult to by heart and remember all the root values of individual. But at least the main nerves, the important nerves, in the upper limb, the lower limb, the cervical plexus, So like that we can remember certain root values, right? For that, so now once again, for this question has been asked, for the lateral cutaneous nerve of the thigh. So what is the root value, right? So once again, this question is an image-based question. So they have put a lumbar plexus here, right? From the lumbar plexus, they asked you this question, right? So which nerve is involved in Meralgia paraesthetica and what is the root value? The question was actually the root value, right? So which means you should be very thorough with the lumbar plexus here, right? So coming first directly to the answer for the question, and then we'll discuss about the lumbar plexus, right? So the lateral cutaneous nerve of the thigh, arises from L2 and L3, say here. So this is the lateral cutaneous nerve of the thigh. Okay, so which means the lumbar plexus has got many nerves like the brachial plexus, right? So directly from the T12, it may contribute, right? From here we have the subcostal nerve, right? So since it has been given the picture, I have written. And from L1 we have two nerves arising from L1, ilio-hypogastric nerve and ilio-inguinal nerve. Okay, ilio-hypogastric and ilio-inguinal nerve. And from L1 and L2 we have the genitofemoral nerve, which once again divides into femoral component and the genital component, right? The femoral component will supply the sensation, the skin over the femoral triangle, and the genital component will supply the scrotal area, right? From L2 and L3 we have the lateral cutaneous nerve of the thigh, and you already know from L2, L3 and L4 we have the femoral nerve. Here we can see here, we have the femoral nerve and the obturator nerve. Okay, from the L2, L3 and L4 we have the femoral and the obturator nerve, and from L3 and L4 we have the accessory obturator nerve. Okay, so these are some of the nerves which are arising from the lumbar plexus, right? So what will be the answer for this question? L2 and L3. It was a very straightforward question, right? There is no twist, there is no turn in this kind of question. They're very straightforward. That is why this year anatomy question was actually very easy question, sir. Okay, because it was all straightforward. There's no twisting in any kind of question, right? So once again, revising this, the lateral cutaneous nerve of thigh arises from L2, L3, dorsal division L2 and L3, and it's a pure sensory nerve which supplies a general sensation in the thigh, in the anterolateral aspect, upper part of the lateral aspect of the thigh. And the Meralgia paraesthetica is a clinical condition where there will be a pain and numbness and burning sensation, very commonly due to diabetic, right? The patient comes to you with a pain and in any kind of neuropathic situation, the patient comes to you with pain and burning sensation, okay, in the anterolateral aspect of the thigh. The typical scenario will be the Meralgia paraesthetica, okay, because of irritation of the lateral cutaneous nerve of the thigh. So once again, a direct question. And the fourth one, football player sustained an ankle injury due to forceful eversion. So this is an eversion type of an injury, right? So the foot is now displaced outwards like this. So which ligament is most likely to be injured? Once again, this kind of question we already discussed in our recall, 1 month before the exam. We have already recalled this one. So I already told you the ankle joint can be divided into 2 ligaments. Okay, the support of the ankle, because it's a weight bearing joint. The ankle joint can be supported by on each side, medial and lateral, by 2 principal ligaments. On the medially we have the deltoid ligament. On the laterally we have the tibio, the network of tibio from the fibula, right? From the fibula, lateral malleus to the talus to the calcaneum and navel. Okay, so from the medial we have the deltoid, and from the lateral we have 3 constituents, the ligament. One is talofibula, posterior talofibular, anterior and posterior talofibular, and calcaneo. Now comes the question where there is an eversion injury here, right? Which means the foot is displaced outwards, which means more amount of pressure is put on the opposite side, which is on the medial side, which means which ligament is now getting more strained and pressured? It is the deltoid ligament, okay? So once again, in case of an inversion injury, the lateral ligament can be injured. In case of an eversion injury, the medial ligament, which is the deltoid ligament, can be injured. So once again, because of the pressure created by the stretching of the ligament, because of an injury. How severe the injury depends upon the nature of the insult of the injury, right? Is that clear? So once again, to consolidate, over the ankle joint, on the medial aspect, we have the deltoid ligament, and on the lateral aspect, we have the talofibulocalcaneal network, right? We have the anterior talofibular, posterior talofibular, and calcaneofibular. Okay, they form the network, right? They form network which supports the lateral aspect of the ankle joint. Is that clear? Right? So next question, I think it's a very easy question, no? Structures present posterior to the epiploic. Once again, it was actually a clinical scenario kind of question they have asked, no? So one student who put in the group is when a surgeon who was doing a perforated duodenal ulcer, okay, inadvertently, right, he injured a vessel which is present posterior to the epiploic foramen. Okay, so what is the vessel he has injured? So like that, the clinical scenario has been put, right? So which means what is the structure which is present posteriorly to the epiploic foramen, right? So what is actually a epiploic foramen, or called the foramen of Winslow? A foramen which connects the greater sac to the lesser sac. That is called the epiploic foramen. Okay, the foramen which connects the greater sac to the lesser sac. Okay, so very importantly, internal herniations are very common in that foramen of Winslow, right? So once again, so we have the scenario here, where we have the foramen here, the foramen of Winslow, which is we have the caudate lobe of the liver, which is bounded superiorly, and we have the first part of duodenum, which is present. Okay, we have the first part of duodenum, and we have the caudate lobe of the liver, right? So over the anteriorly we have the hepatic artery, portal vein, and bile duct, which is present in front, and what is present behind will be the IVC, right? So very important landmark, and once again this landmark will be very much stressed, during the when we study about the duodenum, right? So during the first part, we see, what structure is present in front, what is present behind. So in that we study epiploic foramen, right? If you recall, if you think what you have studied in your first year MBBS, you will know, right? So once again, the foramen which is present, behind. Sorry, the structure which is present behind the epiploic foramen will be the inferior vena cava, right? So once again, it's a clinical scenario type of question they have asked, right? But once again, the question directly comes to what structure which is present posterior to the epiploic foramen. Okay, so the answer will be the IVC, the inferior vena cava. Once again, look at the picture. You find the hepatic artery, portal vein, and the bile duct are present anteriorly, and above you will find the lobe of the liver, the caudate lobe of the liver. And what you find below will be the first part of the duodenum, and the structure which is present just behind the epiploic foramen will be the inferior vena cava. So that is a structure which can be injured inadvertently in case of an mishappening during surgery, right? So it can lead to profuse bleeding and even death on table, right? So once again, a very beautiful question. So it's like, putting laddu in your mouth, right? So which cranial nerve does not pass through the marked foramen? For that, you need to know what is that marked foramen, right? Which means you need to know what are all the major foramens present in the skull, right? So only if you know that, you can answer this kind of question. Once again, it's a very, very, very easy question, right? So it's it does not even classify under a tough type of question. No, it's a very, very, very easy kind of question. So the marked foramen is a jugular foramen, right? This one, the blue one, the marked foramen is a jugular foramen, and you already know in the jugular foramen we have the 9, 10, and 11 cranial nerves are exiting out of the jugular foramen. Okay, the 9, 10, and the 11 cranial nerves are exiting out along with the important vein, the jugular vein, internal jugular vein. Okay, so the odd man out here will be the 12th nerve, because that will be exiting out of the hypoglossal canal. Okay, so this will be the odd man out. Okay, many of the student has this confusion. Sir, is that jugular foramen or is that internal acoustic meatus? Okay, internal acoustic meatus do not have an outer. They are showing the base, outer aspect of the base of the skull. Okay, acoustic meatus do not enter, will not be shown here, right? So it has got an opening on the interior aspect, but it does not have an exterior aspect. Is that clear? The facial nerve exit from the stylomastoid foramen. Is that clear? So there we have this beautiful jugular foramen, and from this jugular foramen the 9, 10, and the 11 cranial nerves are exiting out, which means the odd man out here will be the hypoglossal nerve. It's a very easy one, no? Right? So once again we have discussed this kind of question, and this is the one question where where we have discussed already a very direct question. And you won't believe, even the statement, what they made the statement is similar to the one which we have discussed in our recall session 1 month back. So it was an RWF question. Okay, so in this picture they have shown you, okay, a structure, okay, and they have asked you from which pharyngeal arch artery, aortic arch arteries this structure derived from, right? So here they have the arrow mark indicated will be the patent ductus arteriosus, okay, the one which connects the pulmonary trunk to the aorta, right? So it was fetal, it is essential for it to make sure that the blood is adequately circulated, okay, because the lung is non-functional during the fetal life, okay. But here question is a very direct question. So PDA is derived from the persistent ductus artery, derived from which arch artery, right? So the answer for this question will be the choice was given between the right 6th arch and the left 6th arch, okay. The students were actually confused, so they know it belongs to 6th arch artery. But once again, they have been confused whether it belongs to right or it belongs to left side. So that is where even some students have gone wrong. Sir, I put 6th arch, but unfortunately, I have selected right arch artery because two choices was given. One is right 6th arch artery, and other one is the left 6th arch artery, okay. So once again, I like to make it very clear. On the right side, we have the proximal part of the pulmonary trunk, okay, and on the left side, we have the ductus arteriosus, okay. So in the fetal life, it is called ductus arteriosus. When it is persistent, even beyond the fetal life, it becomes persistent ductus arteriosus. Is that clear? So on the right side, we have the pulmonary trunk, proximal part, and on the left side, we have the ductus arteriosus, okay. I'm very, very happy to say that, this was a direct question what we have discussed here before the exam. The similar scenario, even the statement has not been changed, okay. So the answer will be the 6th arch and on the left side, okay. Remember, arch, is towards the left side, right? So PDA, the ductus arteriosus present on the left side, distal to the subclavian artery, right? Next question, a very, very, very easy question. Umbilical cord has the following structure, right? I already teach, there are two eyes and one mouth. Okay, there are two eyes and one mouth. So two eyes, the two arteries, and one mouth is a vein. Okay, with the water and jelly mixed between that. Okay, so similar, right? So two arteries and one vein. So there is nothing to prove the umbilical cord has got two arteries and one vein. Okay, so umbilical cord has got two arteries and one vein. So very, very, very easy type of question. This time they have asked. Okay, so two artery and one vein will be the Okay. Next question, once again a clinical scenario based. Okay, a 20-year-old male presented to the emergency department after a blunt trauma to the nose. He has continuous anterior nasal bleeding. On rhinoscopic examination, blood is actively oozing from the antero-inferior part of the septum. Okay, so here there is a clue here, the antero-inferior part of the septum. So this is a place where the causal back plexus will be present, right? The causal back plexus will be present. Which artery is most likely responsible? So now when it comes to the blunt trauma injury to the nose, and whenever there is a bleeding present, very commonly the venous bleed is very common. But whenever there is a severe blunt trauma or RTA and there is a rupture of a vessel, right? So over the anterior-inferior aspect of the nasal septum, right, we have a lot of vessels contributing, right? But among that, there is one vessel which is majorly responsible for supplying the antero-inferior part of the septum. We call that vessel as an artery of epistaxis, right? And that vessel is called the sphenopalatine artery. Okay, that artery is called what? Sphenopalatine artery. It is an artery of epistaxis. Even though the anteroethmoidal artery, the superior labial from the facial artery, and the greater palatine from the maxillary artery all do supply, the major blood vessel for the causal batch plexus come from the sphenopalatine artery. So that will be the answer for this question. So if you look at the chart here, from the internal carotid artery, we have the anterior ethmoid and the posterior ethmoidal artery. Here, one more thing, posterior ethmoid do not contribute. Okay, this one do not contribute to the causal batch plexus. Okay, the causal batch plexus is present in the antero-inferior part of the septum, where the posterior ethmoidal artery do not contribute. And from the external carotid artery, we have the facial artery. From there, the superior labial artery, and from the maxillary artery, we have the greater palatine and the sphenopalatine artery. And this artery, the sphenopalatine, is the artery of epistaxis. Okay, so for this, the answer will be the sphenopalatine artery. Next question. Here, once again, they have made a picture for this question, right? They have indicated an arrow showing you the mylohyoid, then they have asked you the nerve supply of the mylohyoid. Okay, so very easy question, no? So what is the nerve supply of mylohyoid, right? So first you have to identify that they have given mylohyoid because some have identified as a digastric. Okay, because it is present, the mylohyoid forms the oral diaphragm, So first of all, you need to identify what kind of muscle they are asking you, and then we have to find you have to select the correct answer, right? So for the mylohyoid, it is supplied by the first pharyngeal nerve. The nerve of the first pharyngeal arch will be the mandibular nerve. Okay, and from the mandibular nerve, okay, it divides into branches as it exits out of the foramen ovale, right? So how does it exit? So from the foramen ovale, okay, from the foramen, the foramen ovale, right? The mandibular nerve, okay, as it exits out, it divides into two branches, the anterior branch and the posterior branch. Okay, the anterior branch supplies the muscles of mastication. Okay, supplies the muscles of mastication that include the temporalis, the lateral pterygoid muscle, and the right. For the medial pterygoid, it arises directly from the trunk. Okay, nerve to medial pterygoid. Medial pterygoid arises directly from the trunk. Okay, so principally it's a motor division. The anterior branch is a motor division. You have the anterior branch. Okay, it's a motor branch, but we do have, so it supplies all the muscles of mastication. But we do also have a sensory nerve that is called the buccal nerve. They all come from the anterior division. So posterior division, it is once again is going to be divided into three branches. Okay, so we have the lingual nerve, we have the inferior alveolar nerve, and we have the auriculotemporal nerve. Lingual nerve per se goes to the tongue. Okay, per se goes to the tongue to supply the general sensation in the anterior two-thirds of the tongue. Okay, it supplies the general sensation to the anterior two-thirds of the tongue. The auriculotemporal nerve loops around the middle meningeal artery. Okay, so we have the middle meningeal artery traveling very close to the auricular nerve. So the auricular nerve loops around the middle meningeal artery. Okay, middle meningeal artery. And what happened? The auricular nerve, as it what happened as it loops around? Okay, it supplies the 5 important components over the parotid region. Okay, 1, the skin here, skin over the temple. Number 2, one gland here, parotid gland. Number 3, one joint, temporomandibular joint. Number 4, one tube, external acoustic meatus. Number 5, one membrane, tympanic membrane. Okay, so that is the fate of the auriculotemporal nerve. But the question here is which nerve supplies the mylohyoid, the inferior alveolar nerve. Okay, as it enters the inferior alveolar canal to supply the teeth, right? It is divided into posterior inferior alveolar nerve, middle inferior alveolar nerve, and the anterior inferior alveolar nerve. Okay, so we have a branch called nerve to mylohyoid branch. Nerve to mylohyoid. And this nerve to mylohyoid branch supplies the mylohyoid and the anterior belly of digastric. Okay, remember only the anterior belly of digastric, not the posterior belly of digastric, because that will be supplied by the facial nerve, the second pharyngeal arch nerve. Okay, so the anterior belly of digastric and the mylohyoid are supplied by the nerve to mylohyoid. Is a branch of the mandibular nerve, which in turn is one of the major division of the trigeminal. So that will be the answer for this question, right? Okay, so which nerve, next question, a very direct one, which nerve does not contain general somatic efferent component? Soma means body wall. Which nerve do not have this kind of component? Okay, soma means body wall. So the muscles which arises from the body wall, that include the extraocular muscles, and the muscles of the tongue. So which means the nerve which carry the general somatic efferent component include 3, the oculomotor, 4, the trochlear, 6, the abducent, and the 12, the hypoglossal nerve. So these 4 contains general somatic efferent component. So which means the odd man out here. The facial nerve, okay, do not supply the muscle from the body wall, because it supply the muscle which are derived from the mesoderm, from the pharyngeal arch, not from the body wall. Okay, so once again, it's a very straightforward question. No, we have to just pick up the odd man out. So GSE means general somatic efferent means 3, 4, 6, and 12. Okay, the oculomotor, the trochlear, the abducent, and the hypoglossal nerve. Right? I believe and I hope this time you would have performed well in your anatomy exams, because this year 2025 the questions were very easy and straightforward, and I congratulate all the students, and I want them to get their PG of their choice this year. Thank you so much.